right, everybody, we are ready to get started. I'm just going to stand close to this so they can hear. And welcome to everybody also online. I have the great pleasure of introducing Kim Ellis, who is a PhD student at Vanderbilt in the training program in human genetics. Her doctoral research is looking into sex-by-ancestry interactions of asthma and environmental modifiers in African ADMIXED populations. And with this work, Kim, do you go by Kim or Kimberlyn?
I go by Kim. My mom's like, I didn't name you Kim. So
Kimberlyn, to make her mom happy, hopes to dismantle health disparities and improve health outcomes for underrepresented populations. Prior to being a PhD student, Kimberlyn received her Bachelor's of Science from Spelman. And I thought it was really cool that you did a lot of this policy related work. Like you had one of these fellowships, I guess, from the American Society of Human Genetics and also from NASM to do work there. That's great. And she has just been awarded the Gilliam Fellowship for Advanced Study by HHMI and the Human Genetics Scholars Initiative by the American Society of Human Genetics. And with that, take it away. I look forward to hearing about your work.
No worries. I love all the teamwork and support. This is great.
There you go.
Perfection. Thank you. Thank you, Dr. Tishkoff, for that fantastic introduction. I am so excited to be here today and be speaking to you all about me and my current doctoral research, which is investigating sex-by-ancestry interactions of asthma and environmental modifiers in African descent ADMIXED individuals. Before I begin, I'd like to give some acknowledgements. Thank you so much, Dr. Jaffe and the Department of Medical Ethics and Health Policy for having me, and Dr. Tishkoff again, and the Penn Center for Global Genomics and Health Equity. I'd also like to thank my home institution, Vanderbilt University, specifically the Vanderbilt Genetics Institute, for all of their support and guidance over these years. And so if I had to make an image that kind of explained all of my research interests, it would look like this. And before we go into how each of them relates to what I do now, we're going to talk about me and my background and how that has informed my research and me as a researcher in general. So I was born and raised right around the corner, 40 to 45 minutes away from here in Audubon, Pennsylvania. I have two older sisters, one of whom is not the star of today's presentation and one of whom is. So to the one who is not, I am sorry. But the one who is the star is the one in the coral dress. Her name is Jasmine. And she had very small beginnings, both metaphorically and literally. So Jasmine was born at 20 weeks gestation. That does classify her as a micropreemie, and they have a 50% morbidity, chances of morbidity. She was born weighing 1 pound, 12 ounces. She was in the NICU for 4 months before coming home. She did receive supplemental oxygen. And so although Jasmine is older than me, and so I was not there to experience this, I grew up hearing all the stories of how she could fit in the palm of your hand, and my parents had to make her homemade diapers because they could not find diapers small enough for her. My mom would buy dolls and take the clothes off of them so that she could have clothes to wear. And this was not an uncommon occurrence in my family by any means. On my father's side of the family, my immediate family members, everybody who tried to conceive either had a one child loss, one child who was born extremely premature, or a combination of the two. And so no one really explained this to me because I was a child, but I just grew up thinking, this is strange. I don't think this is normal. I don't think other people are having these experiences. And I thought about it quietly in the back of my mind my entire life. And it wasn't until I was walking into Spelman's Science Center for class that I saw a sign that said, conduct research, get $2,000. And as a broke graduate student, that really resonated with me. So I walked myself to the computer lab to draft up the one-page research proposal and immediately thought about what interested me, and preterm birth came to mind. And so when I started looking at the literature, I found 3 things that were fundamental to my research trajectory. One, I learned of the health disparities between Black women, Black non-Hispanic women, and white non-Hispanic women. and how Black women have 2 times greater risk for preterm birth, and how this risk is not solely explained by socio-demographic factors, and it's possibly a combination of several interacting variables from parental genetics, fetal genetics, the microbiome, socio-demographic variables, etc. And this was huge for me because not only was it my formal introduction to health disparities, it made me aware of different factors that can contribute to health disparities. And it also made me realize that these different factors can interact. And I love this quote by Zora Neale Hurston, research is a formalized curiosity. It is poking and prying with a purpose, because truly this did formalize my curiosity and allowed me to really delve into something that is the reason why I'm here with you all today. And so that's how I got started researching health disparities and the genetic and biologic determinants that influence health disparities. And so if I had to summarize my undergraduate research, it would look something like this. For my first project, I researched differential gene expression of preterm birth of women who give birth prematurely with Dr. Lee, Associate Professor of Biology at Spelman College. And for our first project, we were able to identify 20 differentially methylated genes in Black women who had given birth prematurely that weren't seen in women of other races and ethnicities. And so this suggested that epigenetic mechanisms may play a role in post-birth outcomes for Black women. And we continued upon that project and focused on SEPT9, and we found it to be associated with the development of bladder urothelial carcinoma in Black women who do give birth prematurely, which suggested to us that this may act as a potential biomarker for bladder urothelial carcinoma in Black women. Eventually, I took my research to Case Western Reserve University with Dr. Pete McFarland, Associate Professor of Physiology and Biophysics, and I developed a neonatal rat model of airway hyperreactivity, and we were looking at bronchopulmonary dysplasia. And so we went to investigate the role of hyaluronan in this hyperoxia-induced reactivity, and we found that it may actually play a substantial role and explain some of the hyperreactivity that we see in preterm infants with bronchopulmonary dysplasia. Once I graduated from Spelman College, I went to Brown University for a year to do their post-baccalaureate, to do the NIH's post-baccalaureate research education program for 2019 to 2020. I was in Dr. Phyllis Dennery's lab, and so what I was doing was I was exposing mice to hyperoxia for different time points depending on the organ system, allowing them to recover in room air for various time points, and then harvesting the lungs, trachea, and main stem bronchi. And so we all know what happened in 2020, so I did not get my full year's worth of research, but in that time, I'm still very proud of what I've done. I was able to be a contributing author on 2 publications. That was really such a great experience for me. So that leads me now to being a PhD student at Vanderbilt University and the research that I'm doing now. And I'm so excited to be doing this talk, especially because I am an incoming 4th-year student. And so I'm excited to hear all your tips and advice because those things can easily be implemented because this project is still very much so ongoing. Before I dive into my research, I want to go over some conceptualizations and key terms with you all. So the first one is that race is not genetic ancestry. And so genetic ancestry is defined as inherited DNA from specific ancestors, and it is a measure of genetic similarity, whereas race is not. Race is a socio-political ranking system that's based on perceived biological similarities. That distinction is very important. And so as a result, race is often correlated with subjection to social and structural inequality. And so these are all images of fraternal twins, but at first glance, you might easily look at them and assume that they're different races and conflate that they probably have very distinct genetic ancestries, when in reality, they share a lot of genetic similarities. And so when we look at genetic ancestry, an important concept that comes to mind is admixture, which is generational recombination among previously isolated populations with distinct haplotypes. And so admixed individuals, as a result, have a unique DNA composition from their ancestors due to the recombination of these haplotypes. And so admixture is reflected in global ancestry, ancestry-driven haplotype frequency across the genome, which you see here in figure A, and local ancestry, the ancestry-driven haplotype frequency at a specific chromosomal location, which you see in figure B. And so African Americans in the United States are a great population to look at admixture in because their global ancestry proportions are estimated at about 80% African and 20% European ancestry. Of course, those proportions differ regionally in the United States and often differ due to differences in slavery prevalence during the transatlantic slave trade. And so here is an image from ASHG, the American Society of Human Genetics, and it shows the route of the transatlantic slave trade from 1515 to 1865. And you can see that that bottom region of the United States got some of the highest, those slaves that were taken there had some of the highest day present populations of African descent individuals. And so if you look at this map, this is a distribution of slavery in the United States in 1860, and you can see that the density of slaves really correlates to the percentage of African ancestry that you saw in these initial transatlantic slave trade routes. And admixture in African Americans is particularly interesting because local ancestry estimates on the sex chromosomes differ greatly from autosomal estimates. And this is due to unique recombination events on the sex chromosomes because, as we know, mothers can only contribute their X chromosomes where fathers can contribute an X or a Y chromosome. And so for African Americans, the proportions of European haplotypes observed on the Y chromosome are about 35 to 40%, whereas the proportion of African haplotypes observed on the X chromosome are about 80%. And we find this particularly useful when we're determining patterns of inheritance that's respective to both sex and ancestral differences. And so this indicates the prevalence of admixture events between mothers of African ancestry and fathers of European ancestry. And this is actually reflective of sexual violence by free European males and enslaved African women during the transatlantic slave trade. Race, on the other hand, like we said, is a socio-political ranking system that changes throughout history. And so a great place to look at how race has changed over time is the United States Census. So in 1790, the census was created, and the categories that were on the census at the time were free white males, free white females, all other freed persons, and slaves. In 1850, you saw the additions of categories such as Blacks, mulattoes, Black slaves, and mulatto slaves. In 1870, you saw Chinese added to the census, and that was directly due to growing quote unquote concerns over the Chinese immigrants that were immigrating to the United States to work on the Central Pacific Railroad in 1970s, and ultimately resulted in the Chinese Exclusion Act from 1882 to 1892, which was a 10-year ban on Chinese laborers immigrating to the United States. In 1890, you saw the classifications of quadroon and octoroon added to the census. So 1/4 Black and 1/8 Black. In 1910, you saw other added, and that was actually primarily used to classify Koreans, Filipinos, and I quote, Asian Indians. In 1920s, you saw Hindus used for, and I quote, Asian Indians, regardless of their religious affiliation. And in 1930, you saw the one-drop rule, and that was directly added due to Arkansas passing Act 320. And the one-drop rule stated that a person of mixed Negro and white blood was to be returned as Negro, no matter how small the percentage of Negro blood. And so it basically relegated second-class citizenship to anybody who was accused of having African ancestry. It also made interracial cohabitation a felony, so interracial marriage, but it did not make extramarital interracial sex or sexual violence a crime. In 1970, you saw, in 1930, you also saw Mexican added on the census for the first time, but it was promptly taken off, and nothing was added in a similar category until 1970. where they first added Hispanic origins after these beginning conceptualizations that Hispanic origin was separate from race. As recently as 2019, Black, African, and Negro was still in the census, and Negro was not removed as a racial category on the census until 2020. The next concept is that biological sex is different than gender. So biological sex, when I talk about it, I'm talking about biological differences which may or may not be manifested physically, which is important. And so we often think about biological sex as this sexual dimorphic trait, when in reality, sexual differences between what people perceive as two groups are actually more overlapping than we initially think. And this is because biological sex is actually a multifactorial phenomena of biological factors ranging from genetics, epigenetics, genome regulation, sex-specific regulatory networks, and hormonal profiles. And it affects a wide range of biological functions and outcomes, such as sex-specific risk factors and mortality outcomes. Whereas gender is the social, psychological, cultural, and behavioral aspects of self-identification and or social participation. And so karyotypes and biological factors may or may not represent gender identity. A great example of this is complete androgen insensitivity syndrome. And so it affects 1 in 20,000 births, and it is an inherited developmental disorder. And individuals with this disorder have an XY karyotype and they have testes, but they have an insensitivity to male sex hormones. So testosterone does not influence their development. And so they actually have an absence of male genitals. Because male sex hormones, they're insensitive to male sex hormones, they do produce female genitals, but they have no ovaries or uterus. And ultimately, usually this is not diagnosed until after puberty because these individuals do not menstruate and do not have pubic hair as they develop. A lot of times though, if it's not caught after puberty, it's caught when these individuals come into clinics and are trying to get pregnant and have extreme infertility because XY individuals cannot get pregnant. And for my work, I'm really trying to reframe the terms that I use to be more precise. So I'll be using the terms individuals with majority African ancestry, individuals with majority European ancestry, individuals with 2 X chromosomes, and individuals with 1 X chromosome and 1 Y chromosome. And so I study asthma, which is a chronic respiratory condition that has a gamut of symptoms, but ultimately results in the narrowing inflammation and increased mucus production in the airways of the lungs. It's characterized by coughing, shortness of breath, wheezing, and chest tightness and pain. And there's no gold standard for diagnosis. It's based on several considerations. It is 45 to 55% heritable in adults and can be as high as over 55% heritable in kids. And only 5% of asthma risk variants identified in individuals of majority European ancestry are replicated in individuals with majority African ancestry. And it can be exacerbated by pre-existing illnesses such as COVID, RSV, and anxiety. And I really find asthma to be heterogeneous with many subtypes, although the most common subtype is allergic asthma, which affects 60 to 70% of asthmatics, and that's often due to environmental allergens. But people can have multiple subtypes that are influenced by each other. So when I think of asthma, this is what I think of, where you can characterize it in many different ways, from age of diagnosis, temporal onset of symptoms, symptom persistence, irritant type, and comorbidities. Asthma has some really interesting sex disparities. And so it actually exhibits both sex and ancestry disparities, but when we're focused on sex disparities, the childhood asthma prevalence ratio for XX to XY individuals is about 1 to 1.5, but adult asthma prevalence ratio, it flips, where XX individuals to XY individuals, you see a 1.7 to 1 ratio. And asthma is 40% more prevalent and severe in XX individuals after puberty. And existing literature suggests that sex hormones may be a potential cause. When compared to individuals of majority European ancestry, individuals with majority African ancestry are 1.5 times more likely to have asthma, 2 times more likely to have an asthma-related hospitalization, and 3 times more likely to die of asthma. And so Black XX individuals have the highest rates of asthma cases and mortality rates in the United States. And this is thought to be due to a combination of various factors, such as ancestry-specific factors, behavioral, social, and structural determinants of health. And there's a well-characterized relationship between environmental factors and asthma. Environmental factors have been known to increase asthma risk. And individuals with African ancestry disproportionately bear the brunt of environmental risk factors in the United States. And they can range from social to structural, as often social variables are the results of structural policies and systems. And because of this, failure to incorporate racialized environmental exposures into genetic analyses can lead to inflation of our genetic associations. And so as a result, I also look at the socio-historical context of asthma when I do my genetic analyses. And this is because medicine is considered objective, but history shows that knowledge of disease pathogenesis was and continues to be highly subjective. This is Dr. Ajioma Kola. She is a postdoctoral research associate at Notre Dame. This work, she works on this very heavily, and she's the author of the forthcoming book, I Can't Breathe, Racism and the Rise of Asthma in Black Urban Communities. So in the early 1800s, asthma was defined as wheezing, shortness of breath, but the patients were mostly doctors, writers, poets, aristocrats, and they were rich, white, XY individuals, so individuals that were socialized as men. And they were thought to have asthma because of their elite status, their privilege, and their whiteness. Many lived in urban areas. And so as a result, asthma was first conceptualized as a nervous condition instead of a respiratory condition. And it was thought that their intellectual fatigue and the burdens of being elite and cultivated caused them trouble breathing. And so there was a high conflation between asthma and anxiety, which I can understand because, you know, anxiety can exacerbate asthma and vice versa, but it is not due to being white. So in the 1890s, we had the first recorded cases in medical literature of Black people being diagnosed with asthma. And it caused such a stir that white doctors and researchers started to debate if Black people could even have asthma because they were not seen as rich and elite and cultivated. And so Blacks with asthma were misdiagnosed with every other nervous or respiratory condition under the sun. However, from the 1930s to 1940s, Black newspapers were already routinely documenting Black patients with asthma. It wasn't until the 1950s where Eurocentric medical literature began to document Black people and asthma again, and this was 60 years after the first documentation. And they realized that Black patients from similar communities were all experiencing asthma. And so medicine was very segregated after emancipation. From the 1950s to 1960s, you saw integration on a large scale basis, not just schools and public service institutions, but also hospitals. You also saw the white flight, where a lot of white people moved out of the cities and into the suburbs. A lot of Black people moved from more rural areas into the cities. And you also saw the civil rights movement from 1954 to 1968. And during this time and to this day, Blacks were subjected to poor outdoor air quality, low socioeconomic status, healthcare discrimination, poverty, housing, insecurity, and redlining. And so redlining is especially pertinent when we're talking about asthma. It's a discriminatory practice in which services are withheld from potential customers who reside in neighborhoods that are classified as hazardous to the environment. And the 1930s brought about FDR's New Deal and the creation of the Federal Homeowners Loan Corporation. And it withheld services such as credit and insurance, bank loans, home sales, and healthcare to people who lived in these hazardous neighborhoods. As you can probably suspect, hazardous neighborhoods often had significant numbers of racial minorities, ethnic minorities, and low-income residents. And so while the 1964 Civil Rights Act prohibited discrimination on the basis of race, color, religion, sex, or national origin, and it also forbid discrimination based on sex and race in hiring, promoting and firing, it didn't say anything about redlining. And so it wasn't until the Civil Rights Act was amended in 1968 where we saw the Fair Housing Act that prohibited discrimination concerning the sale, rental, and financing of housing based on race, religion, national origin, sex, etc. And so what we have here at the bottom are two maps of different neighborhoods in California. The one on the left is a 1940s map from the Homeowners Loan Corporation, and it categorized different neighborhoods based on quote unquote desirability. So green indicates best, blue indicates still desirable, yellow indicates definitely declining, and red indicates hazardous. If we look on the right, we see a 2019 map that's been digitized, so the rainbow one, of that initial 1940s map, whereas the purple one basically shows asthma-related emergency room visits per 10,000 residents for those on the same census tract according to those original maps. And so you can see that the red most hazardous neighborhoods also have the highest emergency room visits. And so asthma is now viewed more as being emblematic of a civil rights issue. And in 1970, the New York Times were writing articles saying that Blacks' increased asthma rates were actually caused by the civil rights movement. I love this picture of one of the articles that they initially did in print because it says cause still uncertain, but they make some very strong conclusions when you read it. So they actually say that Black people protesting for equal rights and their anger towards white people causes their inability to breathe, and which manifests in asthma. And so as I'm learning about asthma and I'm reading the literature, I'm seeing these trends, I'm seeing the sex disparities and the race and ancestry disparities and how these racialized environmental variables increase asthma risk. But what I'm not seeing is the literature explaining or even like suggesting the possibility of a sex by ancestry interaction. And I see a lack of individuals examining the modifying effects of these racialized environmental variables on known asthma genetic risk variants. And so that brings me to my work, which along with looking at health disparities and the genetic and biologic, I'm also looking at the behavioral and the social and structural determinants. And so our overarching hypothesis is that sex and genetic ancestry interact and are modified by environmental factors to increase asthma risk in individuals with majority African ancestry. And so our goals for this project is twofold. Our first goal is to provide an ancestry-aware genetic risk score for precise asthma risk detection and prevention in individuals with majority African ancestry. And the second is just in general to provide the basis for deriving local ancestry-informed polygenic risk scores. And so I'm currently doing pipeline implementation and validation, and I'm doing it in BioView, which is Vanderbilt's repository. And you can think of it as this three-tiered nested entity where we have this synthetic derivative, which is a de-identified image of the electronic medical record. We have BioView, which is our DNA samples that we have available, about 320,000. And we have our redeposited genotypes that give us GWAS data in subjects with any genotyping. And so the median length of our EHR is about 1 year. Max is about 30 years. One thing you have to really keep in mind is that Vanderbilt is a tertiary care center, so people are getting their primary and secondary care elsewhere. So generally our patients are sicker. The median length of EHR records for genotyped individuals is about 12 years, and the average age of a BioView participant is about 58 years old. Once I get our pipelines up and running in BioView and validate that they're working correctly, we're going to implement them in BioView, which boasts a high percentage of minorities and individuals underrepresented in science. Here's just an example. So as of late, they have about 385,000 electronic health records with about 489,000 biosamples. And so that brings us to my project. And so our first aim is to identify specific variants that are modified by sex in individuals with majority African ancestry. For this, we hypothesize that sex moderates the effect of ancestry-specific X chromosome risk factors for asthma susceptibility. The second is to provide effect estimates for genetic risk factors that are adjusted for environmental risk. And we hypothesize that social, instructional, environmental risk factors modify genetic risk factors for asthma and creates a positive interaction that increases asthma susceptibility. So when we focus on the first point, that brings us to our pipelines. So when you're doing local ancestry pipelines, the first step is ADMIXED, which you use to phase your chromosomes of your cohort to a reference population. And it provides local ancestry estimates with higher accuracy at increased rates than other modeling approaches. One thing that's really great about ADMIXED is that it can also be used to utilize, to call local ancestry on the X chromosome. And so our inputs are going to be our genotyped cohort data, which right now is BioView participants, later will be all of us participants, and our reference population data, which I'm using from the Human Diversity Genome Project or Human Genome Diversity Project and 1000 Genomes. Our outputs are local ancestry estimate files across the autosomes and X chromosome. From there, we use Tractor. You can easily think of Tractor as a combination between admixture and GWAS. So what it does is it uses local ancestry to jointly analyze and local ancestry estimates with SNPs. And it's widely utilized to conduct GWAS in populations with complex admixture patterns, and it allows for a more robust analysis. So for Tractor, your inputs are going to be your local ancestry estimate files and your SNPs associated with asthma. For our SNPs, I'm using a multi-ancestry GWAS conducted by the Global Biobank Meta-Analysis Initiative. And our output are covariate adjusted effect estimates for both genotypes and local ancestry. Next, we're just going to do some logistic regression modeling, where we input our SNP risk allele effect estimates and local ancestry effect estimates. And we calculate these models using, like I said, the effect sizes from local ancestry and genotype, sex, and the multiplicative effects of sex and local ancestry, as well as sex and genotype. And then our output is a calculation for quantified effects of sex and genetic ancestry on asthma prevalence. For our second point, which is providing effect estimates for genetic risk factors that are adjusted for environmental risk factors, we're going to be working in All of Us because unlike BioView and many other electronic health records, All of Us does a really great job of reporting environmental variables and standardizing those variables across participants, which if you're working in usually a traditional electronic health record, you would have to make some kind of algorithm and the variables may or may not even be included in the notes. And so it's really a headache to parse those out. But All of Us is great because we know things from what type of housing do you live in? How long have you lived there? What is the housing like in your neighborhood? Do you have any rodent, mold, insect infestations? What's your access to green spaces, which is really great information to have. And so for this, we're also going to be doing some more logistic regression modeling where our inputs are going to be our SNP risk allele effect estimates, our estimates for local ancestry, our demographic variable data, biologic variable data, and environmental variable data. And our output is going to be a calculation for quantifying the modifying effects of environmental factors on sex-specific genetic asthma risk. And so for my current endeavors, like I said, I'm implementing this pipeline in BioView as we speak. I'm also going to be quantifying and categorizing our cohort based on global ancestry proportions instead of race. I'm going to be grouping individuals on majority African ancestry or majority European ancestry. I'm currently working with an asthma specialist on my committee, a physician, to do some asthma subphenotyping because it is so complex and has so many subphenotypes that often aren't accurately captured in an EHR. And eventually we're going to be currently working on expanding our reference population and cohort population to include three-way ADMIXED individuals as well. For future research directions, like I said, we're going to be implementing this in all of us. And we're going to be adding some additional environmental variable data because all of us has, you know, a decent amount of environmental data. It is not all encompassing. So for example, I don't have things like lead exposure, which would influence asthma susceptibility. So we're going to do some work with overlaying some information from the Area Deprivation Index, EJ Screen, which is an environmental justice tool. And what I thought is really interesting is that the CDC actually geocodes regions in different states from least to most rural. And so because you have the first three zip code numbers of every participant in all of us, and potentially maybe even some more granularity than that, currently having some conversations with people about that, I'll be able to do some geocoding and overlay this data to kind of see if we can get more ideas for what's going on with the environmental variables in different areas. And so that brings my circle to a full circle. And so for LC and health policy, that's really what I would love to focus on for my postdoc research. And so I have a couple ideas, still brain working, but I brought you my favorite two of projects that I would like to work on while I'm doing my postdoc and potentially collaborate with you all if I'm doing a postdoc here at Penn. So the first one would be to investigate the utilization of local ancestry informed analyses in clinical settings. And so I came up with this idea because my PI, Dr. Davis, and Dr. Elizabeth Atkinson at Baylor, she created the Tractor Pipeline. They have talked about me potentially just doing local ancestry for everyone in BioView, because there are a bunch of different groups who are trying to do local ancestry in all of us, because there are a bunch of different groups trying to do local ancestry in all of us, and we're all kind of just reinventing the wheel. And so if I'm putting this information out there, I want to know the potential ramifications, because we've seen, for example, in other developments such as CRISPR, how sometimes the science can move far ahead of the policies and regulation that make sure that that science is used appropriately. So I would want to know, how would this utilization differ from current race-specific analyses, such as lab values and transplant lists that have often caused more harm than good? I wouldn't want this to be just a fresh coat of paint. So I would really want to know, does this improve health equity, or does it just perpetuate discrimination? I would also want to potentially research how insurance companies might utilize this type of technology. I could see it being utilized in billing codes, insurance premiums, even some kind of local ancestry informed polygenic risk score to determine genetic vulnerability and healthcare liability. I'd be really curious to see if they would go as far as potentially coverage discriminating for ancestry specific susceptibility of disease. The other idea that I have kind of builds upon the work that I'm doing already for my thesis work, and is a little bit more methods heavy, but I thought it would be really cool to identify the influence of genetic ancestry on pharmacogenomic responses to asthma medications in diverse populations using local ancestry, because like I said before, only 5% of asthma risk variants in individuals with majority European ancestry replicate in individuals of majority African ancestry. And I'm still, dreaming and brainstorming, so I'm not married to these ideas. So I'm so excited to hear any kind of suggestions or comments that you all may have. I want to give credit to credit is due. I want to credit the Davis Lab and our fearless leader, Dr. Davis, who we love so much and truly are so happy and have the best time ever. I also want to thank my committee. I'd like to thank my funding sources, and I'd like to thank my family and loved ones. Thank you all for being here with me today. If you'd like to connect with me further, you can scan this QR code and it'll take you straight to my CV and contact information. Again, thank you so much for the invite. I love being here. Take care.
We have time for questions or suggestions.
Yes,
Sounds
let me
like
get
you
my
also want to
notebook.
Just get feedback about ideas and
Please.
things that could be done in the future.
Absolutely. Yes.
So at lunch, we kind of alluded to the legal protections for some of the health insurance issues that you raised and acknowledged that laws change, protections change. But another related question is about what gets priority for getting approved by the FDA and covered by Medicare and Medicaid and, you know, and private insurers. I think that even if there's not a legal way to discriminate whether people can get health insurance coverage, the drugs that target specific variants or things like that might be on a slower path to approval.
Yeah.
I think might interact with the ideas that you're thinking about.
Yeah, so the comment was to also consider when drugs that would potentially be like using more of these more targeted analyses for diverse populations would become accessible, if they would become accessible to people with Medicaid and Medicare. And based on different like socioeconomic statuses, like really how would people have access to this? Who is it accessible for? And if we can probably assume that it's probably going to be accessible for those who have the closest proximity to healthcare and healthcare services and wealthier populations that can afford insurance and insurance premiums, that may also cause some disparities that are worth looking into. Thank you. Anyone else have a comment or suggestion? Yes.
Thank you. Any plan to categorize asthma into mild, moderate, and severe? I mean, I understand and testing with severe asthma.
Okay.
We have a good quality data when it comes to severe asthma and then see all those factors. So categorization. And then the other big one is when do you want to exclude individuals like with XO, like under symptom, or you know, who are not XX or XY? Why do you want to exclude? Is that because they are rare? And then the third one is how do you define majority? When you say majority, African majority, European.
Yeah.
Do you have allocational definition for the majority?
Yeah, those are great questions. I'm going to say them in order to make sure that I remember. So the first question, okay, so asthma subphenotyping, how are we subphenotyping? I'm actually waiting for someone to get back to me and reply to my email about that. So we were going to use FKB and look at some of the, because they've already done some asthma subphenotyping, some groups at Vanderbilt for that resource. And I wanted to take a look at what they've done first and what we can build upon that to make that more precise instead of like starting from scratch. I'm really trying to work hard and work smart, and I also need to graduate. So we're trying to add granularity to what is already available for asthma subphenotyping instead of creating the entire thing from scratch. And then can you remind me of your second question?
The second one is excluding the other.
Yeah, that's hard. That's really hard for me. I think that's something that I would love to look at if I have the privilege of having enough time. I may need to go back. That's actually a great idea. Okay, I may actually need to go back and discuss that with my advisor because yeah, that would be a good point to look at when we're looking about the sex differences. I try to be as inclusive as I can, and I think that's an additional way that I can do that. So thank you for bringing that up. I really appreciate it.
The majority.
Oh, the majority, yes. Okay, so I am still like working on how to classify people. I was thinking that I could do, I'm going to be doing local ancestry, but I was thinking before that I could also, or while I'm doing that, I could also do global ancestry proportions and literally define people if they have like more than 50% European ancestry, more than 50% African ancestry. This is going to get very muddy, especially when I start to look at three-way ADMIXED populations. I don't know as of right now what I'm going to do for that. So if anyone has any suggestions, I would absolutely love them. Yeah, so for example, it's a terrible term that just homogenizes populations, but like Hispanic populations would be considered three-way ADMIXED because they have the European ancestry, the African ancestry, and the Native ancestry. And then, of course, you're not really technically going to see a lot of individuals from those populations having 50% European or African. And so I need to figure out terms, but I also don't want to over categorize people where it kind of mirrors the categorizations that we've done for race. So I'm trying to I have to figure out how to be as like thoughtful, but as precise as possible.
Well, why do you use the category?
Yeah. I guess I don't. Do you have anything that I can like read or recommend? Because I think as scientists, I think it's easiest for us to put people into categories, but that's also caused so much damage.
Yeah.
Do you, please help.
I think you can avoid categories if possible.
Okay, and just do it based on like percentages?
This is in the context of the reference box for local ancestry.
I mean, this is looking at African American, right? But I guess there were reference populations, you do have to be like, these are represented. I mean, that's what you don't have to.
Yeah.
Well, can I go ahead and read this question? Because it's like.
Yeah.
So, it's from Kimberlyn.
Okay.
Which is my lab. I can read it with, local ancestry methods in African populations is often difficult in practice due to the fact that local populations are extremely admixed, and the reference populations themselves may be admixed. So it could be difficult to determine the correct reference population to use. Do you come across this issue in your analyses, and how did you determine which reference populations to use when looking at local ancestry?
Yeah, so that's a great question. So the question is, in case anybody missed it online, is just how do we determine which reference populations to use for local ancestry and African Americans? Because the reference populations and the cohort populations are both admixed and may have different configurations of admixture. That's a great point. I consulted to people that do this a lot more and are way more knowledgeable to me. I am not afraid to ask for help or advice at all. And so one of the members of my committee, Jibril, he is our genetic ancestry expert person that was actually, he did his PhD with Dr. Tishkoff. And so he's been really great and helpful with me with our analyses. We have a really long, surprisingly long reference population that we're using. And so we're using reference populations from the Human Genome Diversity Project and 1000 Genomes. If those are not a good fit, then we will find another reference population source to see if that's a better fit. One thing that Dr. David Samuels and I have discussed, he's the chair of my committee. We've also talked about just including everybody in as for the reference populations for the 2-way and the 3-way admixture, just so that it doesn't get as confusing as muddled when I then add in the 3-way admixture to the population. So we're trying to currently figure out what is the best reference population. I don't think we've hammered that down yet, but we will be testing to see which one fits the best and then probably proceed with that one.
Go ahead, sorry. Okay. Well, can you go to your the previous slide or before that, where you're talking about what you might want to do? Thought we could brainstorm.
Yes,
Yeah.
I'm excited. Okay.
Well, I mean, so I was thinking that one thing that would be really cool actually is, as we talked about, looking at African immigrant community, because of the switch in environment, right? It could be a cool way to try to tease apart genetic and environmental factors. I'd be really curious to know what happens in terms of asthma. I don't know if you know, if there's any from the Ethiopian community. I don't know if you've heard if there's like any increase in asthma when people come here, for example. Yeah. So that could be kind of cool. And then the local ancestry and PRS. I mean, there's just a lot to be done with that.
Yeah.
Right? To figure out how we can make PRS more accurate, because that's a really interesting ethical question. I mean, should we even be using PRS? Is it even informative?
Yeah.
How much does it even tell you about risk for asthma, for example? Is it relevant at all?
Mhm.
And how can we do better? Because usually it's estimated based on European ancestry because individuals, because those are the biggest sample sizes. Can we do better? You know, how accurate are they? And if we incorporate the local ancestry.
Absolutely. I just want to quickly summarize your points because they're great and I want the people on the chat to hear them. So Dr. Tishkoff said comments about how it would be really interesting to continue some postdoc studies looking at African immigrant communities because of the switch of environments, and we could relatively well study the genetic versus the environmental. And she also mentioned local ancestry and polygenic risk scores and how interesting it is, and should we even be using polygenic risk scores, or how informative are they? How can we do better? And potentially investigating if adding local ancestry in there could potentially make it better and more accurate. Yeah.
I'm gonna ask a question that's probably basic to almost everybody else in this room. Advanced to me, which is what's the hypothesis about what sort of the biological impact of local ancestry is, or how might it be exerting its effect beyond, for example, the alleles or the variants that happen to be in the place that are sort of correlated with that local ancestry, so that once you know something about the local, those alleles, those risk alleles, which may differ from one ancestry population to the next. Like, what's the hypothesis about what local ancestry adds from a kind of biological risk perspective?
Yeah, that's a great question. So Dr. Joffe's question is, what does local ancestry add from a biological perspective when you're looking at like asthma risk variants? And so my train of thinking is because asthma risk variants in European populations are not replicated well in Black populations, only 5% actually replicate. By doing local ancestry analysis, we can go to these specific risk SNPs and see if these will, let me go back. So by actually using GWAS summary statistics from a population that matches our cohort population, that gives us more accuracy right there. And then when we look at the exact position of these asthma risk variants and see, okay, this risk variant that may or may not be contributing to their asthma, is it coming from like an African risk variant or European risk variant? And then to me, environmental is huge. Environmental is huge for many chronic illnesses. In fact, many chronic illnesses only have like max 20% genetic component. But biology still significantly matters. And so, and there are real biological differences between ancestry groups. And so my thinking is maybe if we get a little more granularity with like local ancestry specific asthma risk variants, maybe that can improve pharmacogenomic responses or therapeutics in order to move precision medicine advancements for minority populations further. There's also been studies that show decreased inhaler efficacy in Black and Puerto Rican populations when compared to white or Mexican populations. And I'm curious to see if that would be because the way that we're formulating our drugs maybe have some kind of receptor or response that are more attuned to European populations than African populations. There's been research done by other groups, ASTHMA Bouchard at UCSF, who has basically looked at asthma and suggests that African ancestry may contribute to increased asthma risk, where Native ancestry, it contributes to decreased asthma risk. So I'm hoping we'll get a little more clarification in not just the risk variants for asthma in African descent individuals, but also ways in which potentially we can better precision medicine advancements for those populations.
And I would think that rarely do we know the causal variants, but we might know a region. And so it might be informative to know in that region, let's say in a European population, the PRS is done, it shows this region is associated, but only in Europeans. Then you look at someone who self-identifies as African-American, And in that particular position, they're 100% European ancestry. So maybe you get a more precise estimate then of risk, something
Yeah.
like that.
Exactly. Thank you. Yes.
Wonderful talk, because a lot of parallels to my research and activities, so it's really exciting to hear this. So a question that I had, you touched on how all of us as well determinants of health accounts for green space.
Mhm.
I wanted to kind of touch on that a bit more and see if the availability of such green space and environmental hazards, proximity to industrial centers and things like that, and overall environmental discrimination and racism and policy making and whatnot. Are those among your racialized environmental variables? And if so, how are they accounted for?
Yeah, that's great. So the question is basically like, I talk a lot about all these factors that contribute to asthma. And while all of us, at least as of late, to my knowledge, seems to be the most comprehensive EHR with social determinants of health data, how am I really counting those in? Right now, I'm just focusing on housing and neighborhood environments to get like my kind of footing going and make sure my models are working. But there are a bunch of other variables that I would love to add in this, as well as like healthcare discrimination, discrimination in general, stress. I have not looked as deeply into those variables yet, because I'm kind of just getting the ball rolling with this stuff. But I would definitely want to explore them further. I know, I think his name, Professor Tyson Brown at Duke, actually developed a structural racism calculator per state, and he gets as granularity as like voter suppression, etc., and actually like ranks every state based on like a racist score. And of course, like different regions in different states vary. So it's not as precise, but I'm starting to explore like things like that will probably capture in greater detail things that all of us is missing. While all of us is a great resource, it is not entirely comprehensive. So I'm going to have to, just like how I'm going to add additional environmental variable data on top of that, I'd probably have to add additional discrimination variables on top of that as well. Yeah. Go ahead.
So you also mentioned in the future directions you'd like to include area identification index. And so I wanted to ask why you choose that over, say, social mobility index, or because like you'd like to include an index in the future. Because you mentioned census tracts and those are linked with vulnerability indexes. So I wanted to see if you wanted to pivot in a certain direction in the future and change from census tracts and block groups, or just kind of the general idea.
No, you're completely correct. So the question was, why am I using area deprivation index instead of like social deprivation index? I just wasn't as precise with my language on this slide, but that is like a great point and something to consider. Yeah, I'm not thinking like one track or the other. Yeah, I just need to fix my slide. Thank you though so much. I appreciate it. Are there any other questions? Yeah.
How many cases?
Yeah, how many? I had a slide, I hit it, but off of the top of my head right now, when we're looking at all of us, and keep in mind, this is all of us categorized as people by self-described race. So I'm using their language, not my own, but when you're looking at Black populations, and in all of us, Black is wide, so you can be Haitian, you can be Jamaican, et cetera, but they categorize them all under the umbrella of Black. We have about 47,000 Black people total. I really wish I unhid my slide, but about 17, I think I want to say 15 to 17,000 had asthma, and the rest did not have asthma. And those are individuals ranging from 18 to 65. One thing that's really exciting is that all of us is, if they haven't done it already, they're starting to add children. And because of the specific sex differences between children and adults with asthma, that would be something that I would also want to look at, as well as like different racial groups. I said that in quotes. I just haven't gotten the numbers for those individuals yet. They're like still continuously rolling them out. And so I think it's going to be this consistent process where they want to have at least 1 million participants in all of us total. Right now, they have above, I want to say they have about 680,000 individuals. So they're going to keep rolling people out. There was just a big like input of people a couple months ago. And so it'll literally just be me adding new people in as they continue to have new releases. Yes.
Do you know if there's been like any good like GWAS or genetic studies on the pharmacogenetics and pharmacogenomics of asthma medication? Like, do they have, like, are there already known associations, or is that something you would sort of?
Yeah. So I was looking, I don't have those, that data specifically in a slide. People have looked at pharmacogenomic responses of asthma, and they've done it in minority populations. But it wasn't as, if I can remember right, the cohort sizes weren't that large. So, and then also when I'm talking about like my potential postdoc interests and this, it's also me just dreaming. It's me just having a fun time and dreaming and not worrying about, do I have well, the people are important, but like, you know, do I have the money? What would it take to do X, Y, and Z? And so of course, like I know I came into grad school with this huge dream of doing like intergenerational trauma data. And then I'm like, okay, wait, that's really hard. And I don't have the money for that. So I'm sure my projects will continue to become more specific based on like what already exists and then what we have the resources to do. Yeah.
Sorry, so but the current plan, so you're gonna be conducting GWAS.
No,
You're pulling GWAS.
Right.
From people doing that in asthma, from the all of us.
So the all of us is our cohort population. I'm not doing a discovery GWAS.
Okay.
The Global Biobank Meta-Analysis Initiative is a really great resource where they've combined, I want to say, over 20 electronic health records from institutions all over the globe and has a wide range of like populations. And so they did a huge, they have many phenotypes. Honestly, I recommend everybody to go look at that if you're like in this line of work. But they've done many huge asthma GWASs from sex-specific to ancestry-specific to multi-ancestry. And so right now I'm just looking at like the multi-ancestry one to begin with. And I actually, Gerbil's been an angel. If you're on here, Gerbil, thank you so much. He did the leave one out analysis for me because BioView participants are in there. So because I'm starting my pipelines in BioView, I had to take those populations out of my GWAS summary statistics so they wouldn't like kind of mess up my data later on. So I'm implementing these GWAS summary statistics into my pipelines. I'm not doing a discovery GWAS. And I think that's a huge distinction to emphasize.
But the pipeline is like the tracker pipeline you mentioned, where you're including some.
Correct.
Ancestry. So you would be running ancestry, local ancestry estimates on the same individuals that the GWAS was done, and or.
So you use your GWAS summary statistics in order to phase. So you use your. Sorry, let me go back. So we take our cohort, which in my case for this first implementation would be our BioView participants. We input them into ADMIXED and we add reference population data because that phases our chromosomes for our cohort. The output of that is our local ancestry estimate files that we then input those same files into Tractor along with our SNPs associated from asthma, which is what I'm pulling from that previously done meta-analysis GWAS into the Tractor pipeline. And I should have put up there like, and also my cohort. And then from there, based on my cohort, I have like covariate adjusted effect estimates for both genotypes and local ancestry.
I just want to say, it's like 7 after.
Oh.
I know some people have to go because the discussion's been great.
Yeah.
And so just thank Kimberly. Yeah, no,
Thank you. And I'll be after, like if anyone has questions, I'll be here. Thank you everyone so much for joining via Zoom. It has truly been a party. I've had the best time this whole trip. So thank you so much for attending.